Hi, Francesca. It's really good to see you today, and we're going to talk a little bit about ATS and what the kind of major updates were from the conference. First of all, I wondered whether would you mind maybe giving us a quick introduction to you and who you are and maybe a little bit of your background, and then we'll dive into some questions about ATS from your perspective.
Sure. My name is Francesca Polverino. I was born and raised in Italy. I did my medical school in Italy, in Naples, and then I moved to Mallorca in Spain to do some part of. And then I ended up at the Brigham and Women's Hospital, Harvard Medical School in 2010, where I spent almost 10 years. I did my PhD there in the Pulmonary Critical Care division. I became a faculty in 2017, and then after a brief period at the University of Arizona, where I was recruited to set up a COPD research group, I moved to Baylor College of Medicine, where now I am an endowed professor of medicine in the Pulmonary and Critical Care division, and I run the COPD research group here at Baylor College of Medicine. So I am an MD, PhD. I see patients as well in a county hospital, and my main interest is in the COPD pathogenesis and early origins of chronic airflow limitation.
Great. Well, it's really great to have this conversation today. I'd love to know from your perspective, what were the kind of major trial results or the key trials that were discussed at ATS this year?
Oh, for COPD, this year, it was all about the trial that was just published in the New England Journal of Medicine, where they used dupilumab, which is a monoclonal antibody that is currently used, like Dupixent, which is the dupilumab, which is produced by Sanofi/Regeneron. This drug has been extensively used successfully in asthma, and now it has been shown to, it has been used tried in COPD with the eosinophilic component, and has been shown to greatly ameliorate not only the symptoms, but also the FEV1. So all the primary, it's the first time, honestly, that I've seen a drug that ameliorates both the primary affects so deeply, both primary and secondary endpoints when it comes to symptoms, FEV1, and all the rest. So this ATS has been really marked by the success of this trial with Dupixent in COPD.
Brilliant. Do you mind maybe telling us a little bit more? So when are we most likely to make a treatment decision in this space? What are the kind of key indications? What does a clinician need to know about when to prescribe?
So Dupixent is a monoclonal antibody that blocks interleukin-4 and interleukin-13. Right now, it was just used in allergic asthma, eczema, in particular in all the asthma with a eosinophilic component. So what I still have to dive into the paper much, but what I can tell you is that from now on, it is recommendable to, usually, when you talk about COPD and eosinophilia, it's all over the map. People don't know exactly how to handle that. But now with this trial, we do know that eosinophils is a component that needs to be taken into account when designing a treatment strategy for the COPD patients. In fact, as I said, this monoclonal antibody has been shown to work greatly in a patient with COPD with a eosinophilic component. So to make a long story short, it will be recommendable to just measure the eosinophils in blood, and if there is a eosinophilic component, as we do in asthma, this patient is a good candidate for Dupixent.
Super. And in terms of other key results, any other papers that were kind of really interesting at ATS from your perspective?
I cannot tell you about papers, but I can tell you about the topics that were predominant, the COPD word.
Sure.
So this ATS was really the ATS of integration of multiomics. When I say integration of multiomics, is that now the single cell RNA sequencing is becoming very prevalent in the study of COPD. After a couple of major papers that were published where the atlas of the COPD lung was made available, Everybody now is jumping into the single cell RNA sequencing, but then from the single cell RNA sequencing, I mean, it's as good as you can get right now. So everybody's doing that, although it's, you know, if you have deep pockets, you can do that. But now the field is moving towards something that is called spatial transcriptomics, where basically you can have the single cell data with the spatial resolution on tissue slides, which is something that has replaced the laser capture microdissection. And then from there, the people, as myself and other investigators in COPD, are trying to integrate this transcriptomic data with the radiology, meaning that we look at the CT scan of these individuals and we try to see if there is any correlation between the radiomics, the radiological features of these lungs with the biological features and the nature of the immune environment that we see in the lungs. So, you know, this ATS was all about integration of multiomics, meaning that everybody's talking about single cell, spatial transcriptomics, and radiology. The three things are about to be merged. People are working hard to try to integrate this high throughput data into one data set that can better define the COPD lung. Like just looking at the CT scan, you'll be able to predict what are the biological features of the lung of some individuals, which is one step forward towards a precision medicine approach in COPD.
Super interesting. How far away do you think we are from that kind of precision medicine approach? How many years, or how close are we?
Well, we are not that close and not that far. The problem is that, so the concept of COPD is evolving very fast in the last couple of years. You know that for many years we defined COPD only with the spirometric obstruction, with the gold recommendation, and this got us stuck for many years because we were stuck with the spirometric obstruction. But now, thanks to a couple of papers that were published, first the Lancet paper where they redefined completely the COPD, and they are not talking about one kind of COPD anymore. Now we're talking about different types of COPD that have different causes that they have called etiotypes, which means different causes of COPD. So now we know that COPD is not just the disease of the old people, a self-inflicted disease of the old people that have been smoking. Now we know that COPD has many phases. One, for example, is alpha-1 antitrypsin. Another one is COPD of people who were asthmatics, and then the asthma chronicized into COPD, even in absence of cigarette smoke. Another type of COPD is the one of the premature kids who were born premature, and the lung, you know, this individual, they were dying before, but now all these individuals are alive because we have the surfactant. So more and more we see in clinic all these people who were born premature and they have never smoked, but they were just born with a low lung function, and they meet the spirometric criteria for COPD. So we know COPD right now, or for example, we know that infections such as respiratory RSV infection in childhood or adenovirus infection in childhood, lower respiratory tract infection can affect the lung for the rest of your life. It can determine the onset of COPD very early in your life. But as you can understand, this is not the COPD as we used to think. This is not a COPD that is associated with cigarette smoke. This is just a COPD as relates to the spirometric obstruction. But maybe in this individual, LABA-LAMA will not work. This is why we need a precision medicine approach, where we need to understand the cause of the airflow limitation in order to tackle these causes. But we, unfortunately, right now we need biomarkers and clinical trials in order to target this subset of individuals.
And where are we on that biomarker front? So that's a really interesting next step, right? Where are we in that research?
So we have been trying to, the COPD field have been trying to look for biomarkers quite a lot. The problem is that blood biomarkers are difficult to find, but for example, previously that microalbuminuria, for example, can be a valuable biomarkers that is associated with the systemic endothelial dysfunction in COPD. And I know that there are trials that are tackling individuals with microalbuminuria, or we just published a study where we show that giving metformin, which is a anti-diabetic drug, to patients with COPD can actually also help ameliorating a subset of individual. Or what we do in the lab, in my lab, we target individuals with emphysema predominant COPD that have off-targeted, and we believe that a monoclonal therapy, a biological therapy targeting B cells, could be beneficial in this subset of individuals. So the field is moving forward. Now I think it's going to move a lot faster now that we have established that COPD is not just the disease of the 70-year-old smokers. So now the field is going to move a lot faster.
And what does that mean for treatment? So were there any kind of major trial updates or findings about what that means for treatment? So if we're going to split this into lots of different subsets, what does the treatment look like in terms of each of those different subsets, and how does it differ?
As I said, the only trial that was positive that is going to have a big impact in COPD is the one with Dupixent. But what I can tell you is that there have been trials. For example, they did a trial with an angiotensin receptor blocker in COPD, because we have shown previously, we and others have shown previously, that there is endothelial dysfunction in COPD. So they gave angiotensin receptor blockers with people with COPD, and the trial was negative. But the caveat is that you cannot just give one drug to all the people with COPD. You have to identify the subset of these individuals that might need, for example, with endothelial dysfunction, that might need this drug. And this is, we published an article last year. It's called "The Selection of the Right Patient Population, the Achilles Heel of Clinical Trials." So the selection of the patient population is really the Achilles heel, the weakness of all these clinical trials that are coming out. And when I say the weakness, is because we do understand that the COPD has different phases, but we keep doing clinical trial by targeting the entire COPD population selected solely based on their spirometric obstruction, which is a major weakness of all the clinical trials that have been coming out so far. So most of the clinical trials where they've been trying these alternative drugs in COPD have been negative. But from my perspective, it's just because the right patient population has not been selected yet.
Super interesting. And then looking forward, where do you think, what are the most exciting ongoing studies right now in COPD? So we've talked about some of the really big published results from ATS, but obviously there's lots of really interesting research happening in the field right now. What are the studies that everyone's talking about? What results are eagerly awaited, and what should we know about those trials?
Honestly, there are so many trials that are ongoing right now, and there is nothing specifically that is popping out or that is coming to my head right now. I know that one big thing right now is the repurposing of drugs. For example, there was a session, very well attended session at the ATS, where we talked about repurposing of drugs that are used for other diseases in COPD, just because we now know that COPD has this metabolic component with an accelerated aging component. So we are trying to repurposing drugs from other diseases such as metformin or enalapril or ACE inhibitors that are used in other diseases such as diabetes or heart failure, that have the same nature of accelerated aging and this metabolism. So we're trying to repurpose these drugs into COPD to see if, obviously this is not very palatable from an industry perspective, because, we're repurposing industry, the pharmaceutical company don't make much money, but it's something that is, it's a viable option that a lot of groups are trying to investigate right now. So what I can tell you is that we're moving away from the LABA/LAMA and more bronchodilator, because I think this is as good as you can get. We tried all of them, combination, triple therapy, monotherapy. We try all possible combination. They still work. They still have an impact on the symptoms and progression of COPD, but they're not changing the course of the disease. So we're moving away from the LABA/LAMA ICS. And we're trying different strategies, such as, for example, targeting the inflammation, like the dupilumab, or targeting the metabolism, such as metformin. So alternative strategies.
Really interesting. And in 10 or 15 minutes, that is a really great insight into what was happening at ATS. So I'm really grateful for your time, Prof Polverino. And thank you for kind of sharing your updates with the kind of global community. Really great to get your insights, and really appreciate it.